All right, guys. Mad Medic Slayer here doing our neurology update here. So this is going to be a three-part lecture series on the neurology chapter, and it's a pretty long chapter, but there's some very important things in neurology that we got to make sure that we understand. And I can tell you that the registry, if you start getting popped with questions on this one, the topic is pretty deep. So if you really want to, hit this section hard because these are the questions, quite frankly, you don't want to answer on a regular basis. Okay, so when we're talking about neurology, we're talking about things infecting the nervous system. Okay, again, strokes is a big thing, and a lot of the strokes, by the way, that we get calls to is usually due to falls. Epileptics, again, these are your generalized, but there's more than one form of epilepsy, and so we need to make sure that you understand the difference between the seizures. Okay, Parkinson's disease. The older we're getting more and more cases of these. And again, we get called for a lot of things: headaches, multiple sclerosis, and it's usually the other problems. Neoplasms, by the way, nice way of saying cancer. So again, other nervous system emergencies that we're going to talk about. So we got to understand the anatomy and physiology behind it. Okay, nervous system is our body's control system. It's the fast control system. Okay, endocrinology, the slow control, the more constant. The nervous system is more your quick response. Okay, electrical impulses transmitted between the nerves. Okay, and again, so you got to understand that, and then your circulatory system, it helps by distributing the hormones and chemicals. So our fast control system again is that neurologic system. So the CNS, the central nervous system, the brain, the spinal cord, peripheral nervous system. These guys are your somatic nerves, which is your voluntary function, and then your autonomic, which is your sympathetic, parasympathetic. We talked a lot about these when we were in cardiology, how sympathetic speeds us up, parasympathetic slows us down. But it doesn't only affect the cardiology system, it affects everything, okay? Remember, fight and fight right here, sympathetic. Parasympathetic is your rest and digest part, okay? But this is your peripheral, the autonomic nervous system usually does involuntary function, all right? So the peripheral nervous system is again, you're kind of like a living computer. The CNS is the central processing unit, and then it splits out everything to do the input and output processes, okay? For those of you that are computer based. The neurons, again, is the fundamental unit of the nervous system. Usually the nervous cell is a little bit different. Again, you've got the dendrites, which receive signals, the soma or the central cell body, the axon, which then transmits it out to the synaptic terminals. Synaptic terminals. So again, now we talked about this when we were talking about neurotransmitters as well. Remember that especially when we were talking about RSI, we actually block these guys up. We don't allow it to transmit. So the way that it transmits is by the use of a chemical, acetylcholine or norepinephrine, whichever it is, what type of nerve you have kind of determines it. Sympathetic, by the way, uses again acetylcholine. Sympathetic uses the norepinephrine. Sympathetic uses norepi, and then your parasympathetic likes to usually use acetylcholine. Okay, which, by the way, that's why we use it as atropine as an antidote. By the way, because usually those nerve toxins actually activate that parasympathetic, causing it to go crazy. All right, so again, the resting state is it's positively charged on the outside, negatively charged on the inside, and then sodium rapidly rushes into the cell. We kind of remember this from the schoolyard issues. If you haven't, again, watched that video, it might be a good time to go back and understand that, because not only are we talking about the cardiology cells, but now we're talking about it. It's probably in every cell that you're talking about. All right, so again, and what happens is once that electrical charge goes down, the neurotransmitter transmits it across the synaptic cleft. All right. So again, acetylcholine is for parasympathetic and voluntary. Norepinephrine is your sympathetic nerve fibers. That's where those are the two major neurochemical transmitters. All right. So a lot of the drugs that we use actually help us with that. And so we're going to watch this, and this has to do with reuptake inhibitors. And this will be a little bit more important when we get to the toxicology stuff. But they love to throw questions about serotonin-specific reuptake inhibitors. So this is what they're talking about when they're talking about a reuptake inhibitor. Oop. Let's go back here. Previous and go.
Reuptake inhibitors. At this synapse, we see a typical sequence of events leading up to the release of the neurotransmitter, the red spheres, and its subsequent diffusion across to the postsynaptic membrane. When the Add Inhibitor button is pressed, reuptake inhibitor, the green spheres, attach themselves to the presynaptic transporters and block reuptake of the neurotransmitter. This allows the neurotransmitter to spend more time in the cleft and increases the likelihood of further serial postsynaptic activation. This is the mechanism of action of drugs like the selective serotonin reuptake inhibitors, or SSRIs.
So again, it allows it to stay in there and it doesn't allow it to reabsorb, so it's going to continue to fire on those neurons, which is why they like to use that drug. Now, the problem is of course, they have all kinds of major side effects, and we're definitely going to go into that when we get more towards toxicology. So again, the central nervous system is the brain, the cranial vault. This is kind of a review of our A and P. Again, these are all the different bones. This is where, again, the foramen magnum, that's the only place for your poor brain to go out if there's increased intracranial pressure. Again, these are the different attachments. This is you're looking at the base of the skull. Again, these are the, hopefully you guys already know this. If you do not know this diagram, I would learn it. Because again, if it doesn't pay off in trauma, it's definitely going to pay off in here. By the way, it's the same, whatever's behind these bones happens to be the lobes that are behind the brain, okay? So we got to understand that. Again, your spinal cord, 712-554. Hopefully we all remember this from EMT school. And again, by the way, this is one of the questions that was gotten wrong extensively. I don't understand. What is the cervical vertebrae at the shoulder level? Hello, that would be number 7. And it was amazing, by the way, how many people missed that on the final exam. So again, your meninges, again, these protective coverings, all right? And it kind of becomes important, especially when they get infected or they get blood in between them. Okay, and they can have different symptoms when that happens. Okay, so the dura mater is the outside, the arachnoid membrane is the middle layer. It's like a web light. It's full of blood vessels, and then the pia mater is the endmost. I remember this by the word DAP. That's the way I remember it. DAP is a very common form of putty that you use to fix your drywall. But again, dura mater, arachnoid, pia mater. DAP is how I remember it. Again, both your brain and spinal cord is bathed in cerebral spinal fluid. Again, we get additional pressure. Again, remember, there's not too much of that. So if you start getting brain swelling, that can cause problems, and it can clear it acts as a cushion, but it's also your buffer region. All right, there are 6 major parts of your brain. I would know at least where these are, okay? Cerebrum, diencephalon, pons, mesencephalon, medulla oblongata, we've talked about that guy before, and the cerebellum, okay? And they all do different things, okay? The cerebrum, it governs the sensory and motor functions, your intelligence, your learning. It's kind of the smart part of your brain. The diencephalon is the inside brain, is where your thalamus, hypothalamus, limbic system is. That's where it controls your temperature regulation, sleep, balance, stress, and hormones. And the diencephalon is for your autonomic nervous system, okay? The automatic functions. Now, the mesencephalon, or the midbrain, again, your pons and medulla, they form the brain stem, which is kind of like the starting of the spinal cord. It's kind of the way I remember it. And the mesencephalon is used for your mes motor, okay? Your pons, again, a connection between the brain and the spinal cord. Your medulla oblongata is your respiratory and cardiac activity and your vasomotor activity. Your cerebellum is your fine motor coordination. And when these people are having a stroke, they look like they're drunk. I might want to keep that little fact in mind. But it does, that's where your cerebellum falls. It's the fine motor control, okay? Where, again, back here, again, your diencephalon, or the mesencephalon, certain aspects of motor coordination, the cerebellum is your fine coordination, All right. So again, there's multiple centers. By the way, the speech is located in the temporal lobe. So when somebody gets hit up again in the temples, they start having speech problems. It could be trauma related to that. Vision is in the occipital cortex. So again, somebody got struck in the back of the head. They're seeing double. They're seeing triple. That would be the example. Personality is in the frontal. This is why these people that get hit because they're not wearing their seatbelt and they go into the glass, all of a sudden they're acting really weird. And balance coordination, again, is in your cerebellum, okay? Now, again, sensory is usually in your parietal lobes, which is the top part. Motor is in the frontal as well as the personality. And the reticular activating system, it maintains consciousness. This is what tells us to wake up or go to sleep. And if it's jacked up, your RAS is going to put you to sleep because that's what it's designed to do, okay? Now, again, remember when I said if you don't know the outside of the skull, if you look at the inside, guess what, gang? This is the different parts. And they love to throw in questions about what is in doing what. Like somatic is your premotor cortex. They love to fill in where the olfactory is. So unfortunately, the only way to really do this is to study this and to learn this. And they've got some questions on it that hopefully will help you guys in your quizzes. Now, your brain, remember, it's a nutrient hog. It gets 20% of the body's total blood flow, okay? Only 2% of your body weight, but again, it consumes 25% of the glucose. So if you ain't got blood going through and you ain't got sugar coming in, your brain's going to start acting stupid. Remember that reticulating activating system? It's going to say, nope, we're done, and it's going to start shutting down, or it's going to start deactivating things, okay? Thus, alter mental status, change in patient condition. All right. So your carotid system, again, and this is the anterior, remember that it goes up and it joins at the circle of Willis. Okay. Now, the reason I bring up the circle of Willis, and I want to make sure, remember that it goes all the way around the base of the brain. So again, you could have one carotid clogged up and your brain is still going to get blood. Okay. So remember, it's kind of like a backup system, if you will. All right. So again, your blood flow, the cerebral body, spinal fluid, it bathes the brain and the spinal cord. And then again, your several chambers within the brain also have that fluid in there, which helps control intracranial volume. We talked a little bit about that in trauma. Okay. So again, those ventricles will start to close up. If you've ever seen a CAT scan, they usually have those black things inside the CAT scan. And then if you see somebody with really bad head trauma, those black things are going to be gone because the brain is swollen and it squirted all of that fluid out of the brain so that it can make more space for the swelling. Your spinal cord is about 17 to 18 inches long. Again, remember, starts at the base of the medulla oblongata pons area, and then it goes all through the foramen magnum all the way down to about L1, L2, where it splits into the cauda equina. Okay, and again, that's it helps your major control system as a quick path for sensory and motor functions, basically to keep you out of trouble. Okay. But again, remember that 1 through 5 is kind of where that brain stem goes through as far as the cerebral, the cervical vertebrae. And if you break one of those, of course, now you're messing with your autonomic functions of the spinal cord. Okay. Now, again, afferent is sensory fibers that transfer to the CNS. They're a little bit faster. The efferent travels away, impulses from the CNS to the body, and each nerve root corresponding to the skin and the dermatomes where it's supplied. We talked about dermatomes in trauma. Again, I would probably know some basic areas where those branch out. If you don't have that chart, get that chart off of Google and make sure that you take a look at it. Remember that your reflexes are in the spinal cord. They are a protective mechanism. Again, if you touch the hot stove, your body realizes it's hot, it reflexively pulls away. So again, reflex action, it does not have fine motor control, okay? Now, your cranial nerves, again, you've got 12 pericranial nerves. If you have not learned your cranial nerves, boy, are you in for a rough day at the office, okay? So if you guys all remember the cranial nerves, gang, if you don't remember the face, you need to go back and start drawing the face again, okay? We're going to you will be seeing that the first day of class. There is going to be a quiz on it. Hint, hint, Okay. Now, for those of you that have watched the video, thank you for watching the video. All right. So again, the somatic sensory nerves. Again, these guys are those have to do with touch, pain, pressure, temperature, and then your somatics is they carry the efferent fibers from to the skeletal muscles. Okay. So again, somatic the sensory, and it also controls some of the muscle function. Again, the visceral ones is the efferent tracts that transmit sensations from the visceral organs. So these are, by the way, these are the ones that activate like when you're having chest pain. So now you can kind of see where these interactions with these nerves, and it's causing the problems that you get with these patients, okay? Now, your involuntary is again the autonomic nervous system, and your sympathetic and parasympathetics are the ones that are they work. I'm not going to say in harmony, but they use each other to control, kind of like the yin and the yang, if you will. Again, you can't constantly go all the time with your sympathetic going nuts, and the flip of that is the parasympathetic can't be there all the time as well. All right. So during stress, again, sympathetic dominates. During rest, the parasympathetic is the one that dominates. Okay. We should already know about sympathetic, parasympathetic. Just remember, sympathetic, norepinephrine, parasympathetic, acetylcholine. I would probably try to remember that just a little bit. Now, the pathophysiology of this, okay? Again, the fully individuals responsive to stimuli, they know what's going on. Again, but anytime that you have a problem with the brain, there's a really good chance you're going to get altered level of consciousness, which is why we kind of make a really big deal about that, okay? So if somebody's having a problem, we got to figure out why. Remember, the brain is a nutrient hog. It takes 1/4 of our glucose. It takes 1/5 of our blood supply. So if you've got an interruption in either one of those, you're going to have some sort of neurologic dysfunction, okay? So again, these are the things that we can kind of check pretty quick. If I reach down, they don't have a radial pulse, probably we got a blood flow issue. If I look at their pale, cool, and sweaty, and they're diabetic, and they got their insulin pump on, and I look down and I see their CGM and it says low. Hello. All right. So again, they can't function. The reticulating activating system is going to shut them down. Okay. So now, structural lesions, by the way, can also do this. A brain tumor, neoplasm, I would probably know that those two things are synonymous. Degenerative disease, intracranial hemorrhage, any type of parasite. Yes, we can get amoebas in there, protozoa. There's all kinds of things that can cross that and again start to eat away at brain tissue. Again, and also trauma. Again, remember, if the brain is damaged, it's probably going to have a change in mental status. Remember, if we don't have oxygen, or if we got a toxic state. If I've got too much ammonia, if I've got, the ketones being way too high, if my carbon dioxide is way too high, if my blood sugar is too low, all of these things are going to make a difference, and it's going to cause changes in mental state. What about a renal failure? Yeah, because the toxics are going to build up. By the way, thiamine deficiency. We've talked a little bit about this with endocrinology. And when we give D50, usually we give thiamine as well, especially to your malnourished patient, because these can cause a toxic state, which will change the mental status, okay? By the way, giving sugar without the thiamine can end up in a Wernicke syndrome. You might want to keep that in mind. All right. So, again, your altered mental status, again, if you got drugs, we all know, boy, drugs, yeah, they make you feel good. Too much of a good thing is a bad thing. So again, depressants, hallucinogens, narcotics can all do that. What happens if I've got some sort of cardiovascular problem? They're in cardiac arrest. Well, obviously, they're in cardiac arrest. They're probably not going to be talking to us. Strokes, arrhythmias, hypertensive crisis, hypertensive encephalopathy. In other words, the blood pressure is so bad that it's causing additional swelling. If they're in a shock state, whether it be from anaphylaxis or blood loss or neurogenic, blood displacement where it's not supposed to be. If they're not breathing right, God, we have covered this one in earnest, okay? But again, if they're not exchanging gas, they're not going to be getting oxygen to the brain, 1/5 of the nutrients that you're going to need. Yeah, newsflash, you're going to have altered mental status. What happens if you've got an infection? Whether it be meningitis, encephalitis, if they have an acquired immune deficiency syndrome. Again, that's why they usually are in a altered mental state. And don't and this one's kind of an outlier, but guys, if you know what? We went swimming the other day. Ever since then, he hasn't been feeling good. He's kind of slowly declined. Oh, you went into lake water. Ooh, was it like, what lake was that? And so again, these are things that I just came back from another country and all of a sudden, 2 days later, they're not feeling good. These are the little things in the history taking that can go, hey, we got a problem. All right. So again, your autonomic nervous system, again, it controls it maintains homeostasis. We like homeostasis, okay? What happens if that's messed up? It's going to mess up blood pressure, temperature regulation. All of those things can throw off your central nervous system, okay? Now, again, you got peripheral nervous system disorders as well. Okay, when you got damage to peripheral nerves, okay? Again, tingling sensations, not being able to move, reflexes not being correct, okay? So again, trauma, compressions, infections, all of these can cause mononeuropathy, okay? So you got to make sure that we understand that. And then polyneuropathy, that's more like your stroke. You get a mix of sensory motor issues, toxic agents, metabolic disorders can also cause that. So again, it frequently results in other conditions, okay? So in other words, what they're trying to say is that a lot of things can cause the neurologic problems that the patient's having. It's probably not directly related to the neurological problems, but it causes the other problems that you're going to start to see and start to have. All right, now the general assessment of these guys. Again, the ABCs, obviously, and by the way, remember that the ABCs can be screwed up if some of the systems are not working as far as the control part, okay? But if their ABCs are good, their general appearance, their speech, their skin condition, color, and their gait or their posture, okay? So if I'm sitting, right, again, or I'm, right, again, you have to look at these generalized things and you kind of go, wait. So again, quickly for your mental status, get your APU. And as soon as you get your APU, again, you want to start talking to them. And when we start talking to them, we start getting their mood, thought, perceptions, judgments. And what we might consider normal might not be normal for the patient. So if you've got family around, this is a great time to say, hey, is this person acting like they normally do? Allow me to give you a perfect example. I went to a patient, he's swearing like a sailor, cussing like crazy, going off. The problem is he was the pastor at one of the local really big Baptist churches. And I mean, this guy was saying words that would make a sailor blush, okay? So again, these are the type of things. Well, is this normal? Well, if I'm dealing with a certain type of patient, yeah, and I'm not generalizing here, but if I'm dealing with a certain type of patient, that's kind of normal speech for them. Usually most of the guys in our class. But these guys, again, if it's a preacher who doesn't normally talk like that, there's a mental status change and we need to handle it. Okay. Once you get to the level of consciousness, again, make sure that you maintain the airway, and especially if they're unconscious, they have a cervical spine injury. If they are unconscious, we're going to treat them like they got a broken neck until we can prove it otherwise. Again, don't manipulate that neck unless we absolutely have to. If they are unresponsive, gang, an OPA is usually your friend, but definitely positioning and getting the tongue off the back of the throat, okay? Because remember, that tongue will go flaccid, causing airway problems. And be alert for the absence of a gag reflex. If they have absence gag reflex and they start vomiting, you're going to have bigger problems. Securing that airway probably just got moved up on the list. So again, get your heart rate, rhythm, ECGs, again, the skin color, temperature, all these things are great to do. And again, determine if it's a neurological problem or a medical problem. And sometimes that's very difficult to do. Okay, so again, when in doubt, kind of error on which one's the worst one. Again, we can usually rule out the cardiac effects. We can usually rule those out pretty quickly. Okay, so again, make sure you do your physical exam, head to toe, pupillary response. The eyes are the windows to the soul. Yes, very true, because your reticulated activating system is going to mess up your pupillary responses. Shine the light in their freaking eye, okay? Get where their pupils are, all right? Any drooling or facial paralysis, you want to know that. And if both pupils are dilated and they do not react to light, you probably have some sort of again, reticulating activating system problem. Okay, in other words, they're probably in generalized distress. Usually, if you've got some activity, the pupil is going to change in some one way or the other. They're going to change. Unilateral dilated pupils usually means you got increased intracranial pressure. Usually your constricted pupil is a altered mental status caused by drugs. And then again, any extraocular motions, again, have them follow the fingers. Again, that tells us a lot, and especially toxicological. Um, Head injury patients, guys, if you're doing that with the finger, if you have horizontal nystagmus, okay, if you have horizontal nystagmus, more than likely due to alcohol, this is what they're looking for when the cop tells you to do this. The vertical nystagmus is more indicative of a head injury. Okay, so again, when we talk about nystagmus, what we're talking about is the bounce of the pupil as it goes out farther or goes up and down farther. Okay, so if they're following your finger and they're bouncing, again, up and down, head injury. Left and right, probably alcohol or some sort of other drug or depressant. All right. So make sure you check for contact lenses, any changes that compromise the airway. And again, the respiratory derangement can also occur with CNS illness or injury. Okay. So when they get infected, they can problem that. Look out for we talked about the patterns. Patterns are important for breathing because if they've got messed up respiratory drive function, usually caused from either trauma or some sort of medical issue that's causing abnormal respiratory patterns. Okay, so stay on the lookout for those. And remember, we want a PaCO2 of 40. If they have hypercapnia, they're going to have altered mental status changes probably. And I'm talking like up in the 50s, 60s, 70s. Okay. Again, usually COPDers with a 60, they kind of live in that state. All right. So again, they get acclimated to it. Again, and you got to make sure that visual assessment. Okay. You have to. So make sure you do a good physical exam on these folks. All right. Well, we don't have time to do that. Well, you better make time for it. All right. So again, decorticate, decerebrate posturing, these are all bad things. To the core is bad. Away from the core is worse. Bad, worse. Bad, worse. And truth be known, you really should be thinking at that point when they're getting to this stage, you really probably need to protect their airway for sure. Again, if you are if they are awake, again, you want to assess muscle tone, strength, flexion, coordination, and balance. We start talking about stroke exams, and we're going to do this in class. We're actually going to do, I'm going to teach you guys the MEND exam, but it has a lot to do with the flexion, extension, coordination, and balance to help detect a stroke easier. All right. So, Glasgow Coma score is indicative of survival. And again, if you guys are not good on Glasgow Coma score, by the way, hint number 2, I would probably know my Glasgow Coma score before I got to class onto the first day of class. I would definitely know that. Like backwards, forwards, upwards, down. Okay? Because, yeah, we're going to be majorly getting into that. All right? So, again, always assess these things, your capnography, your blood pressure, blood glucose, and you got an altered mental status patient and you got a CO measuring device, I would probably get that out and start working. Remember, the older that you get, they are more subject to illness, okay? As a matter of fact, I would say also the flip of that's true. The younger they are, the babies, the pediatric patients, they get really affected really easily by these processes, which would cause an altered mental status. Okay, and again, interview family members. Look for these. Again, remember the older you get, yes, you're going to start having breakdowns in those systems. But these Parkinson's disease very important. That's what happens usually as you get older. And vascular emergencies such as stroke is where we kind of get problems. Last but not least is anybody that's suffering from a neurologic emergency, vitals every 5 minutes. Okay, constant reevaluation. Must do, absolute must do, because even those subtle changes can make a big difference. All right, I know this kind of went long, but again, this is a really important topic, especially with your assessment of your patient with these. All right, we're going to hold up here. We'll start on the different managements on the next video.